Okay, we're going to go over basic ventilator settings, modes, and just some common uses and best practice on basic ventilator settings, just in case anyone needs a little bit of a review prior to advancing to advanced ventilator modes, and in addition to just making sure that we have what we need. This is by no means everything, as there is always more to learn. However, this should be a fairly good start for those of you who are newer to the ICU or need a refresh, as well as those of you who would just like to optimize your knowledge. Okay, so this is kind of basically what we're going over here: settings, modes, advantages, disadvantages between different modes, some basic guidelines, and some mild troubleshooting. Okay, so the things we want to talk about are all of our settings. Some settings are definitely ordered, and that's what the doctor wants, But other things I feel like we don't pay enough attention to and we don't always use to the best of our ability. And trigger and sensitivity is one of those, as can be flow rate. So let's go into trigger. So most of the time, our patients are on flow trigger, and that's fine. And that's usually our typical patient that's, tends to be a little older, and they're just going to kind of we want to make it as easy as possible for them to trigger that breath. However, there are some times when we definitely need to switch to pressure trigger. And the main reason we need to do that is for leaks, like when we have trach patients. Now think about it, we're bypassing a lot of that, sorry about that, artificial airway with our trach, right? We have a much less artificial airway, and therefore they are able to trigger more easily. And so generally start all your trach patients on -2 pressure. When we have our neuro patients that we are getting into more and more, especially the young neuro patient, if we have someone who has neuro difficulties, but they tend to be a younger, healthier person, what can happen, and you've probably seen this and maybe didn't know what was going on, your peak pressures are crazy low, like 10, and sometimes your mean airway pressures and your PEEP always almost go negative. This can also happen with really bad Kussmaul's breathing or Cheyne-Stokes. So what you want to do in that case is make sure you're switching over to pressure triggering. That'll help you out of that situation a lot. In addition to the pressure triggering, you really just want to make sure that you're optimizing flow. When they're flow hungry, that can happen as well. Especially this will happen with your taller patients and younger patients as well. All right, let's talk about tidal volume. Now, it is really important to use ideal body weight and not take, people can be 200, 300 pounds overweight. So we're not going to give them a crazy tidal volume based on their actual weight. But you can kind of get a basic idea with their real weight. I did not include the ideal body weight formula. I know it's posted somewhere in the department. The one that we use in respiratory, very different from the one they use like at a personal trainer or something like that. So what we really want to make sure we're doing is always setting 8 mLs per kilo. I cannot tell you how many times we've seen 500 as a tidal volume. And this 500 is not going to be the same for somebody who could be a linebacker and has a wide chest and is 6'4" as it is for a 80-pound soaking wet female. Okay, we need to be setting 8 mLs per kilo tidal volume. If the doctor or the anesthesiologist coming from surgery gives you a setting that is too high, we need to fight for that patient and argue and say, no, this is just too much. Because cardiologists are expecting us to manage those vents, as well as the intensivists will always back you up and do the right thing as far as their tidal volume. They're all very knowledgeable, but sometimes anesthesiologists tend to be a little more old school and use higher volumes. Talking about ARDS, we don't want to expect the unrealistic from these really damaged lungs in ARDS. So we are going to be targeting that 4 to 6. I mean, it's going to be an average, but 4 mLs is okay. Another thing I wanted to mention with that 4 mLs is when we are doing our spontaneous breathing tests, right? We're going to extubate our patient. It is not they have to get to 300 or 400. I hear numbers just being thrown out. No, they have to be 4 mLs per kilo on their spontaneous. Okay, so half of what we would set. So if we set that ventilator correctly and gave them 420, they only have to hit, about 200, 210, if it's a tiny, tiny little old lady. That's their 4 mLs per kilo. Most of the time they'll do better than that, but they did not fail. If their set tidal volume is 400, that is 8 mLs per kilo, and they're only drawing 200 on spontaneous. No, that's not a failure. If it's a much bigger person, then that is. So it's all specified to the individual. All right, respiratory rate is something that we really don't need to pay attention to. We tend to start 14 to 16 at least on our patients. 12 would be reasonable for other ones. Just know that your respiratory rate is going to be your secondary CO2 removal. But once you hit that 8 ml per kilo on tidal volume, we don't ever go above that. All right, so our PEEP. PEEP, we always start at least at 5. We never go below 5. But we need to make sure that we are optimizing PEEP. We will eventually get to an advanced ventilatory class where we will talk about optimal PEEP and how to do the tests for optimal PEEP, things like that. But at this point, just if you saw an x-ray and they have very minimal chest expansion, we need to be going up higher, or if the SATs are not coming up on 100%, we need to go up and recruit some of that lung. And this is all going to be disease specific, but if you know that patient has pulmonary disease, I think what happened with our basic ventilatory stuff is we have gotten away from having a ton of pulmonary disease on a regular basis. What we end up having in the ICU more often than not is they have some other issue and they're intubated to protect airway, whether it's, an overdose or renal failure. And so we've been tend to get away from some of our basic respiratory modalities. So this is just a little reminder. All right, peak flow. So in volume control, your peak flow is not only important for your patient to be able to get the tidal volume, breathe comfortably, not air starve, all of those things, but it's also what is allowing you to have a normal IE ratio. Your peak flow is what's giving you your IE ratio, and you always want to have at least a 2 expiratory on the IE ratio. So it's a ratio. So 1 is going to be the first part until we go to reverse, but that's a whole nother world. So you want it to be 1 to 2. If you're on very high respiratory rates, 28, something like that, 1 to 1.8 might be the best you can get. But you never want to have a 1 to 1. You never want to have anything less than 1.2 unless you cannot help it. Okay, and make sure you're giving them enough flow. We should not have flow set to 30 or 40. 45, 46 sometimes is okay for little old ladies or something, but for the most part, I would start with at least 50 on your peak flows on almost everybody, and you'll be a lot better off. Okay, so let's go back into IE ratios. So we really want to look at our IE ratios. This is something that we're looking at that no one else is really paying attention to. It is our responsibility to make sure that we are giving that patient a normal IE ratio, which we already said is at least 1 to 2. You want to, and think about it, if you were to take a breath, your exhalation would be at least twice as long as your inhalation. Now, there are patients that we need to have longer IE ratios. I'm going to let you pause here so you can shout out the answers or have the answer in your mind. But what disease processes need a longer expiratory time? Don't look at the second part where we're talking about a shorter expiratory time. With the longer expiratory time, these are going to be our diseases of air trapping, right? So our true emphysematic COPD and our asthmatics. We have to make sure these patients have an expiratory time of 3, 4, even 5 if we can. We want to make sure they can get all that trapped air out. Okay, so that's going to be the abnormal IE ratio. The other abnormal IE ratio is going to be ARDS, and this is going to lead into our APRV bilevel. But if we have a patient with ARDS, we want to think about those lungs. So let's kind of imagine what's going on in our asthmatic and our emphysematic patient, right? This patient has all this air trapped in there. And so, yes, you can shove more air in with a machine, but it's hard to come out. So that's why you need to allow as much time as possible to get that air out, just kind of like squeeze out through those tiny, tiny inflamed airways, right? In ARDS, the opposite is true. Remember, like in cartoons, they have like this bear trap that people fall into. I mean, bear traps, I'm sure, are a real thing in some part of the world, but I've only seen them in cartoons myself. So what I'm saying is, when you think of ARDS, you want to think of that bear trap, that it would be super hard to open it, right? It's like no matter what you do, you're barely able to open it and keep it open. So these guys can have tiny, tiny E times because it's taking all the work in the whole world to keep that lung open. It's going to try to collapse instantly the second you stop putting positive pressure. So in these cases, a lot of times we'll do a 1-to-1 IE ratio, and then when we get to APRV or bilevel, which is just different brand names on different ventilators, same concept, then we have a little bit different situation going on. So we because of this situation, we can have tiny, tiny expiratory times because those lungs are going to collapse completely instantly as soon as you stop the positive pressure. So 1-to-1 IE ratios are common with ARDS or very overloaded lungs. Poor compliance is what we're thinking with these patients, right? And when we get to APRV, basically what we're doing is we are messing with that IE ratio. We are holding that air into those lungs for a long, long, long time and then just letting it out for a fraction of a second. Not a fraction of a second, a couple seconds, but I'm just being dramatic for explanation purposes. And then you're going to let that all that air is going to come out. And it's going to try to collapse because these lungs are stiff, stiff, stiff. Okay, so that's our unusual IE ratios. But outside of those two situations, 1-to-2 to 1-to-3. All right, let's go into basic modes of ventilation. So assist control just means is every single breath controlled by the number we put in there? So yes, so we can do assist control in volume, which we usually do, or we could do assist control in pressure. You know, pressure support is obviously a completely spontaneous mode, but most of the time we use pressure support with our SIMV. And this is obviously going to be a better, faster way to get our quick surgical intubated patients that just went into surgery, needed a vent for that reason, and then we want to get them off quickly. So as soon as they start breathing, they're breathing spontaneously. Those intermittent breaths are their own spontaneous tidal volume, just augmented a little bit by pressure support. Okay, I'm going to skip APRV for a second here, and we're going to talk about PRVC or VC plus on our 840 980. Okay, so what this is doing is it is taking the best of both worlds. We are going to talk a little bit about the advantages and disadvantages of each mode in just a second here. But what the PRVC or VC Plus is doing is it is going to take all the advantages of having that volume control. You're choosing the correct, perfect tidal volume for your patient. You're not going to overinflate them because you're choosing the perfect tidal volume. But when you have control of the volume, you have no control of the pressure, right? So sometimes on volume control, the peak pressures go up and up and up. So with PRVC, it's going to give you that magical waveform of pressure control and allow you to choose your volume, but it's going to deliver it like a pressure breath. What does that mean? Deliver it like a pressure breath. Well, have you ever noticed if you take a patient on volume control and these volumes are out of control, which should be your indication that they need to switch into pressure control, and the peak pressures are out of control, sorry, not the volumes. So you set your patient up for 450 or whatever it is, and their peak pressures are 47, right? First thing you're going to do to figure out what's going on with that peak pressure is you're going to do a plateau pressure, right? If the plateau pressure is 45, then that tells you it's not an airway issue, right? That tells you that means that is a poor compliance issue. So you have these crazy peak pressures and your compliance is horrible. So a lot of times what we'll do is we'll switch to pressure control. Now, we just said it's just two halves of a coin. So in theory, when you switch to pressure control, you should also be needing to a set pressure or a set peak inspiratory pressure of about 45, right? No, 9 out of 10 times you could set total PIP of 35, which is still a little high, don't get me wrong. But that's probably going to get you the same tidal volume of 8 mLs per kilo that you had on volume control. And the reason it does that is the way the breath is delivered. It's more anatomically correct. Here, I want you to kind of like go through this with me and kind of imagine what I'm talking about. So on volume control, we have a descending flow ramp, and yeah, it kind of works, but it kind of doesn't descend as much as it could in pressure. So with that descending flow ramp, that means we're giving a lot of flow at the beginning, and then it's kind of tapering off. In pressure control, it really, no joke, 110% is that true descending flow ramp. And what happens is it's going to push a lot of flow in at the beginning, and then it's going to slow it down. And what that's going to do is it's going to allow that volume or that air, the flow of air, to get into all those smaller airways, then smaller airways, then smaller airways, because it has to make turns and go right and left and up and down. It's like a branch of a tree. We're imagining our bronchial tree, right? And it has to make a bunch of turns. And if you keep the air fast, what's it going to become? It's going to become turbulent, right? It is not going to stay nice and laminar. And only laminar flow is going to go the distance and get into all of those distal airways and alveoli. So that's why pressure control is a better mode, because you can do more with less, because it is a better way of delivering the volume. Okay, I know that was a lot. But now let's talk about APRV. So what APRV is it's basically just our pressure control with that kind of inverse IE ratio. Okay, so we're going to set our pressure, and we are going to have the inverse IE ratio. And the big difference on the APRV is we're not going to use the high peeps like we would with ARDSNet, because what we're doing instead is we're going to keep the positive inspiratory pressure at a high level to keep that lungs open. So it's just two different ways of doing kind of the same thing. The IE ratio on pressure control for ARDSNet, or the inverse IE ratio on volume control with the lower tidal volume, or APRV. It's all going to be for our problem lungs, which are our ARDS, right? So this is going to go fast. This is a busy slide. I apologize. So this is just what the advantages are. So obviously assist control is we're taking over the breathing for them, right? Volume ventilation, we are guaranteeing that they are going to get that volume no matter what. Pressure control, I told you some of the advantages. We're limiting that peak inspiratory pressure, which could be barotrauma, but more importantly with volume pressure control is the way we're delivering that breath. And that's going to be important in order to give them maximal bang for your buck, if you will. Okay, pressure support, patient's comfort, they like it. And then SIMV is always better because it does interfere, the slide cut off. It does interfere less with cardiac function. That's kind of why your cardiac surgeons like it. And also it's gonna, on that odd patient that you don't want to not be able to come off the vent, it's gonna allow them to wean more quickly, okay? So we've all seen a patient tank hemodynamically the second we put them on assist control. It just changes the way the hemodynamics and the cardiac system immediately. We can have increased pressures, right? And we can also, have, volutrauma. Barotrauma used to be a thing. It's like, oh, there's too much pressures, it's going to hospital. There is no such thing as too much pressure if there is a reason for it, but there can definitely be volutrauma. Too much volume is a thing, and that's why I really want everybody to fight for their patients and not let them put them on 10 mLs per kilo tidal volumes. Okay. So the problem with pressure control, and the reason they made these combo modes like VC plus and PRVC in the servo, is because if the patient's compliance worsens and you have a set pressure of 25, you can underventilate because suddenly their tidal volumes go from 400 to 200 and you're not really ventilating. So it doesn't adjust automatically. The newer modes do, okay? All right. So let's talk about, we're going to go through the rest of this fairly quickly until we get to the ARDSNet at the end. So initiation. We usually set the FiO2 on the high side, and then we could titrate down quickly. How do we titrate? Well, what the best way to do it is, usually we get a gas, and if the gas is 400 PaO2, something crazy, then we can go ahead and, at least half our FiO2. And then, but another way to do it too is if there's no indication for this patient, let's say it's a surgical patient, to have any lung issue, you can keep taking your FiO2 down by 20. So you can go from 100 to 80, hang out, do a vent check, do your mouth care, do some other stuff. If he's still 100%, remember that old oxyhemoglobin curve? So if he's still 100%, then you can, start weaning down and get a little bit more, go to 60. And then at that point, start going down by fives, go down to 55, 50. Soon as you hit 99, not 100, stop. And then you get your gas. If it's going to be a patient that you think has no lung disease, that'll be a good way to do it, because then you really know that that's a good FiO2 for that patient. Initial tidal volumes, again, I cannot emphasize them enough, 8 mLs per kilo. And this is ideal body weight. With our ARDS patient, we really should be 4 to 6 mLs per kilo. So it's really important that we understand that this is what we're doing. This is the reason we're doing. I've heard people say, it's like, yeah, they went way down on the tidal volume. I'm not sure why. This is why, because we are. And the reasoning behind it is is one, we're going to allow for permissive hypercapnia, because when we get to the point that these lungs are so diseased and so damaged that we have to choose one, oxygenation or ventilation, because a lot of the things on our ventilator that optimize oxygenation hurt ventilation. We have to choose oxygenation, right? The body needs oxygenation. The brain, if we can't keep the brain alive, there's no point for the rest of it. So we have to choose oxygenation. So therefore, we're going to do permissive hypercapnia. But also, we want to make sure that we're not having unrealistic expectations of these lungs. Back in the day, we would try hell or high water to keep the pH in a normal range, to keep everything normal, and you end up beating the lungs up. Yeah, you put the patient on like 14 mLs per kilo, you can probably get the CO2 down, but those lungs are not going to work after that. The shearing pressures, the damage you're going to do to the lungs. So it's really important that we pay attention and we do these things now. And this team of doctors is really good, and they're up on this. So, what controls ventilation? So our primary control of ventilation is tidal volume. If we remember our old calculations from RT school, minute ventilation is tidal volume and respiratory rate. So the whole thing that controls CO2 is tidal volume and respiratory rate. The reason we spend 9 out of 10 times going up and down on the respiratory rate to compensate for CO2 high and or low is because our tidal volume is that line in the sand. Once we're at 8 mLs per kilo, we cannot move it. There's sometimes we'll go a little higher, but 8 mLs per kilo, if you go above that, you're just damaging your lung. And you're solving today's problem, which is a number, and you're ended up creating tomorrow's problem, which is barotrauma and lung disease. So respiratory rate's what we use. So CO2 is high, we go up on the respiratory rate. Now, if we are in SIMV and we have pressure support, also does contribute to CO2 removal or ventilation, because think about it, it's going to make our spontaneous breaths bigger. So if we have a patient on a SIMV of 12 and they're breathing 20 and their spontaneous breaths are kind of small, not doing that much, by taking the pressure support up to 12, for instance, or from 8 to 10, and we take that smaller tidal volume to a bigger tidal volume, that's going to increase our spontaneous minute ventilation, which is then therefore going to increase our total minute ventilation. So it's just something to keep in mind. It's not going to be useful on every patient, but on those patients that it's relevant, it's very relevant. And then again, with our COPD and asthma, or even anybody really, if your IE ratio is set improperly and you're not able to have enough E time, that's going to impede your ventilation or CO2 removal. Ventilation should be considered CO2 removal. It's they could be used interchangeably. Okay. Oxygenation. Oxygenation is obviously FiO2, right? PEEP is our secondary, and PEEP is very important to get to recruit our alveoli. This is even more important on our lung disease patients. And we've talked kind of extensively about this already in this lecture. I don't want to go too deep into it. I time. So that IE ratio that we've been talking about, it's very important if our CO2 is a problem that we need to have enough E time. If our CO2 is fine, or we're doing permissive hypercapnia, and our oxygenation is our problem, that's when I time becomes our third player that will help to oxygenate our lungs, right? And if you think about it, we're going to hold that air in and make those PEEP recruit. And so that's why we end up with the 1-to-1 IE ratios, or even a 2-to-1 IE ratio. So I time is for oxygenation. Mean airway pressure here, it's not a setting on any of our current ICU ventilators. However, mean airway pressure is oxygenation. So if you have these patients with higher mean airway pressure, that is helping you. So sometimes it's very odd to think about it, but the rate will even help your oxygenation. Sometimes you're like, well, my PaO2 went up a lot when I went up by 5 on my rate. And the reason is you're holding that breath in more times. So it's more times per minute. So therefore your mean, which is your mathematical average of your airway pressure, goes up. So just a little side note, but that's obviously picking at straws. That's not going to be one of our go-to tools for oxygenation, but just something to be aware of. Okay, troubleshooting. So we talked a lot about high peak pressures. So high peak pressure is the very first thing before you suction. I've heard a lot of things like, oh, yeah, but I'm in a suction. No. Do not touch the patient. Before you do anything, when your peak pressure is high, you do an inspiratory hold. If your peak pressure is high and your plateau pressure is also high, you do not have an airway issue. And sometimes even that quick suctioning down the tube is going to decrease your, it's going to de-recruit a little bit, and it's not necessary at this moment. So if your peak pressure is high and your plateau pressure is high, you have a compliance issue. You need more PEEP. If you're already on PEEP, you already know what you know. The patient's lung compliance is poor and they probably have ARDS or pulmonary edema, something, CHF. So if your peak pressure is high and your plateau pressure is normal, like 12, 15, something like that, then that patient either needs to be suctioned, and I would always suction first. And if that still doesn't work, then it's probably they need a bronchodilator. This is going to be more important, more true in certain patient populations than others. Obviously, if they are there for something like asthma or COPD exacerbation, then that's what we're thinking right off the get. Okay, ventilator synchrony, sorry, synchrony, I guess they're both correct, is something that should be paid attention to. We will go into advanced ventilation with scalars and loops and how to identify these things in the next lecture that we'll do probably in a couple months. But right now, just make sure that your patient is triggering correctly, and it's something that you just want to pay attention to. And we talked a little bit about pressure triggering. There might be times that you have to put pressure trigger on for those patients that are auto-cycling or over-triggering. And then there's also other times where it's the flow. If they are looking like they're pulling or you can see dips in the waveforms, and again, we'll go into this in more detail in a future lesson, then that's definitely going to be ventilator asynchrony. Okay, so you want to keep an eye out for that. ARDS, we've already talked about how that's going to look. Okay, this is what I was saying a minute ago. If peak pressures are increasing, you do the plateau pressure. Okay. So if peak pressures are high and plateaus are low, you have an obstruction. Obstructions are always airway. So that means it's either bronchospasm or secretions in the airway. That's it. No other things. If both peak and plat are high, lung compliance is poor. All right. PF ratios. When we are doing blood gases, a lot of times people will say like, oh, they're doing fine. PaO2's in the 90s and the 80s. That is not a great thing if that patient is on 100%. Because if they are on 100%, and we're going to use 100% as we go over this PF ratio, super thing, easy formula, PaO2 divided by FiO2. 1 is your FiO2 of 100. Everything lower than 100 is going to be in a decimal, like 0.9 for 90, 0.8 for 80, okay? So to make our lives easy here, we're going to use 100. So if that patient has a PaO2 of 96 on 100, are they doing well? No, they're not doing well. This is ARDS. This is the ARDS scale. right? Technically less than 100 on ARDSnet. I mean, these patients are being considered for ECMO. On 100, if you remember our way back to respiratory school and our total alveolar air equations, when you are on 100%, your PaO2, we'll give everybody a break, assuming these people are not 25 years old that are on our ventilators, 600 at the most. I mean, at the least, the PaO2 should be 600. We've all seen 400s, 500s. That's good. That's what it should be. So if we have a PF ratio of less than 200, then we have issues. Okay. ARDSnet, FiO2, and PEEP. This is something I've seen them do a lot lately. A lot of people are unfamiliar with it. And, technically, if you are needing 100%, you should be on at least 18 to 24 of PEEP, because that means those lungs need to be recruited. Remember my bear trap example. This is like a bear trap. It's like trying to close constantly. You have to keep it open against its will. Okay, so this is ARDSnet. There's different numbers and different studies and over the years, and there's the main one is posted on our board in the department. But just be aware of this, okay? So ARDSnet protocol is high PEEP that matches the FiO2 range we're at. Again, we are going to wean our FiO2 before we wean our PEEP. You kind of wean it in tandem a little bit with ARDSnet, but still you wean your FiO2 before your PEEP. Okay, because your FiO2 is your most detrimental at this point, because at this point when you have ARDS lungs, you already have that non-homogeneous lung going on. You have areas of overdistension, areas of underdistension, you have the ground glass. So the last thing you want to do is cause more lung injury with the O2 toxicity. Okay, so that's the reason we try to do that. So we always do things slow. This is just one I found that was easy to cut, where this is by no means our policy in the department. Okay, just an introduction to ARDSnet. Okay, but on these patients, we are going to be doing permissive hypercapnia, and then we're going to have low tidal volumes. 4 mLs per kilo is usually fine. Okay, all right, that is all I have. I'm going to go ahead and go back to, let me see, the beginning here, and that is really all we're talking about here with this class. As we go into APRV and more advanced modes, more advanced methodologies, I just wanted to make sure everybody has the basics really down pat, okay? We are going to have a skills lab coming up very, very soon. So please reach out for any questions. And I am going to also have these slides printed out for you to take notes on. So please do so. Thank you so much and have a great day.